must constantly look at things in a different way.
The Healthcare Education Transformation Podcast was created by two physical therapists out of the desire to learn more about the different educational roles in physical therapy and healthcare, and how healthcare education works by talking with educational leaders and people with different perspectives within physical therapy and across interdisciplinary lines on how education can be improved to disrupt the status quo of healthcare education. This is our journey, and thanks for listening. Are you a third-year physical therapy student that excels on tests when you have study guides, checklists, and deadlines? With all of the information available about how to prepare for the NPTE, it's easy to get disorganized and not feel prepared going into the big day. NPTE Prep Success is an online course that provides PT students easy-to-use study guides and step-by-step guidance through the NPTE preparation. To learn more, visit kylericeprep.com. Thank you again all for your continued support, and now for the show.
All right, hello everybody, and welcome to another episode of the Healthcare Education Transformation Podcast. I'm your host, Brandon Powen, and of course, as always, I'm joined by my fellow co-host, Dr. Stephanie Wyrock. And today we have two really incredible special guests today to really talk about a few things, but particularly among the themes of that is cognitive functional therapy. And with that, I am so privileged to welcome Drs. Peter O'Sullivan and Dr. Kieran O'Sullivan. And if you guys haven't heard of them, I think you need to look them up because these guys are huge in the research world. But I'll give kind of a brief background and let them introduce themselves. So Peter O'Sullivan is a professor of musculoskeletal PT at Curtin University in Perth, Australia. And along with teaching of that, he also works in clinical practice. And of course, he is recognized internationally as a leading clinician, researcher, and educator in the management of complex musculoskeletal pain disorders. Now, Kieran is also a senior lecturer at the University of Limerick in Ireland, and he is currently on a career break setting up a sports clinic at Aspetar Orthopedic and Sports Medicine Hospital in Doha, Qatar. And they both have also created this online resource, which is called Pain Ed, which is actually really good because it has so many resources for the professionals and public, especially about latest pain research and integration of that to help people. So I really appreciate that resource. And guys, thank you so much for, frankly, all that you've done throughout your careers, because you guys have both clearly shed some light on a lot of things regarding pain and some of these other aspects that, has certainly very much helped a lot of clinicians and patients. Now, I recognize that, there's some people that maybe don't know a bit about you. And of course, I realize there's way more to your bios and what you've done than what I just mentioned. But, would you guys want to just kind of give some other brief background onto kind of who you guys are, what sparked your interest in pain or this in the CFT, and kind of your journeys to kind of how it's gotten to where you are now?
Well, first, thanks very much for the invitation. This is Peter speaking. Where did my journey begin? A long time ago, I graduated as a physiotherapist, or physical therapist as you guys call them, in New Zealand. I would have seen myself as a jack of all trades and a master of nothing. I remember doing dozens of courses on spinal manipulation and mobilization and muscle balance and goodness knows what. And I really got to a point of frustration where I realized I either had to go and do something else in my life or get further study. So I was very privileged to end up in Perth, Western Australia, working under some really impressive people like Lance Toomey, Max Usman, Bob Elvey, and others who probably your listeners don't know about, but they set a very important platform for us. And I credit so much to those people for their open-mindedness and their willingness to question. That really paved the way for me, I think, as a young physiotherapist who was very frustrated in my lack of understanding and ability to manage difficult pain problems, to take me on both a clinical and a research journey, which is really what my last 20 years has been, an evolving process of understanding of pain, and then developing different strategies that I was never taught at the beginning to better manage it, but also exercising a lot of beliefs that I'd grown up with that were just truths in my mind, that both my research or our research and that of others has made us realize that actually a lot of what underpinned our practice was belief-driven and not evidence-based. And so, as you said, I spend half my time working with tough cases who predominantly seen dozens of people and really just got stuck. who are disabled with pain, and the rest of the time I work with a wonderful group of people, and I've been privileged to work with Kieran as well, looking at researching this really tough problem of pain and the impact that it has on people's lives, and the way the systems operate, that really often contributes to the problem.
So I guess like a lot of people, I first became interested in physiotherapy because I was making associations with sports injuries and sports rehabilitation and that kind of thing. And I guess like a lot of people then, when I went through the physiotherapy degree, I was a bit underwhelmed by some elements of the program, and particularly in terms of how broad the training is and in terms of the focus on elderly people and, broader rehabilitation. And when I first qualified as a physio, I was not sure whether I was going to still be a physio 10, 20 years later, because I really liked the people I worked with and worked with some great patients. But a lot of the work I didn't find very stimulating, and some people got better, some people didn't, but I had very, very little clue as to what was going on and what I needed to do to help these people get better. And I guess even from a personal insight, we'll say when I was younger, I played quite a bit of sport. I was reasonably good at it. And one of the things that prevented my progression as an athlete was the amount of injuries I got. And that was the term I would have used at the time. However, now I would characterize them as being more like persistent aches and pains that I didn't cope with very well, or didn't manage very well. And they had an impact on me in terms of my personal life and my sporting life, but they reflect, I guess, the journeys that a lot of patients go through as well, in that like I conceptualized my aches and pains entirely as a tissue injury problem, and I treated it and managed it entirely as a tissue injury problem. And while that was part of the problem, it clearly wasn't the whole solution. And over time, I've been lucky enough again to go and do a master's in Curtin University, where I first met Pete and people like him. And over the last few years, I've worked with lots of like-minded people, and indeed people who disagree with me, that have made me appreciate the role conservative rehab in all its forms, including physio, but not limited to physio, can have in persistent pain and I guess the disability that goes with that.
It sounds like you both have kind of a common ground in being clinicians who had difficulty treating persistent pain and went after that curiosity to continue to provide better care for your patients. So for our listeners that maybe haven't heard of cognitive functional therapy, would you be able to explain kind of what that specifically is, what it's comprised of, and what type of patient that this approach is meant for?
Yeah. Well, we had quite a lot of discussion as to what we would call this approach, because it was an approach that really evolved over a period of time of an integration of understanding pain neuroscience, understanding the importance of communication, understanding that pain often is associated with a whole lot of cognitive or belief-driven processes, as well as negative emotions such as fear and distress that are embodied in the person with pain. And so, I've had a day-to-day of seeing numerous people who present to me with pain and are disabled and have developed these protective behaviors of guarding and avoiding that then leaves them disabled and trapped. And so the idea of the cognitive being the making sense of pain and the behavioral being the embodiment of pain, and that people develop behaviors that in themselves have become highly provocative, behaviors around avoidance and protective guarding. And so both the cognitive and behavioral being critical components of that intervention. And I think what we've seen in the research world is we often see these siloed approaches. So the physical therapist goes, well, I'm dealing with the physical stuff, and the psychologist is saying, well, I'm dealing with the cognitions and the emotions. But often those two things are not well integrated. And so this was really an attempt to try and integrate this for one clinician to kind of unravel the complexity of the person's beliefs, emotions, and behavioral responses to pain, and to frame an intervention that could target all three of those factors. And so it has been an evolving practice and continues to evolve as well in terms of the way we understand what we're doing and the kind of obstacles that go through with that. But it was a term that we developed really because it was the best thing we could think of that described what we're doing. With regards to who we think benefits with this approach, I have a view that I use this approach with everybody: with back, knee, hip, ankle, similar beliefs, similar to pain, irrespective of pain area. But where we think it's potentially very helpful is for people who've maybe have gone through that first stage in primary care, because we know a lot of people get better anyway. For the group that are stuck, we know that these cognitive, emotional, behavioral responses to pain are often the barriers to recovery. So that's where we've placed our intervention studies, to look at the people who are really stuck, because we know those people, if they don't get well managed, escalate into taking opioids, getting injections, spiraling into surgery and becoming very disabled and stopping working. And so we kind of see this intervention as a really middle space to better deal with pain. But I think people often see it as the elements of the intervention should begin at day one, in my mind, with anybody with pain, that people are armed with evidence-based information. People are given strategies to better self-manage their pain and address lifestyle factors as well.
Kieran, is there anything that you want to add?
I guess the only other thing I would add, again, I would reiterate what Peter said about the CFT approach not being limited to one part of the body or time frame in terms of the persistence of a pain condition. I'm not particularly tied down to what we call an intervention like this. I think because there's such a cognitive focus on it, having that term in the title is useful. The word functional is a funny one, because I would say the rehab we do is very functional in terms of it's driven by the goals and desires of the patient. However, any kind of exercise in the world is pretty much labeled functional these days, so it's lost a bit of its utility. One thought, I guess, that comes to mind around this term is that I would say it's pretty much just a how-to guide for implementing a biopsychosocial approach of care. So in terms of whether we look at depression, obesity, fatigue, and back pain, we know there's a mix of factors, and CFT is like a framework within which we address which components of the biopsychosocial model are most relevant in a patient at one point in time. In terms of, I guess, where people view it, I've had two very different forms of feedback on it. One being that this is so different from what physio practice and physio training is that it's almost dangerous, because if you start talking about any psychological factors, it's beyond the scope of practice of physio. And we can come back to that. But equally, I've had people say, well, actually, no, this is what I'm already doing. It's so standard, so much standard practice that there's no need to tell anybody this. Everybody knows this stuff. And I don't know which of those two perspectives is right, but they definitely can't both be right.
No, I completely agree with that. I think that's a very interesting way that you kind of put it there, with kind of how it's basically integrating and kind of utilizing the biopsychosocial model to meet that patient on all those aspects wherever they are. And, and I think that's great. And you guys have done, I know, a lot of research regarding this, and of course, a lot of other topics as well regarding this. But let's go through very briefly kind of what do we know about CFT and what do we need to learn more about, especially looking at, its clinical effectiveness, because I know you guys have done some good stuff into that.
So, look, in terms of what we know at the moment, I don't think there's any question at this stage about the importance of cognitive, emotional, and behavioral factors in terms of pain. I think that's a done. Now, you might argue about it, but at the end of the day, there is really overwhelming evidence that things like people's illness perceptions and their behavioral responses to pain can really set a trajectory for life. And we've captured that in some of our epidemiological data, showing that people who hold negative pain beliefs are more likely to take time off school, seek care, avoid physical activity, etc. And those kids are likely to be predicted to be the adults who will do the same thing, taking time off work, etc. in adulthood. Other groups have also demonstrated this. So in my mind, there's no doubt that those factors are really important. And the research that we've done has looked at what things look to be important, and so Kieran can talk to this as well in some of the work that he's led. But it looks like those things are way more important than things that we as physical therapists historically thought were important, where we were thinking biomechanics, muscle imbalances, joint dysfunctions. Those things tend not to be very important at all in terms of being predictors of people's pain and disability. And so the underlying understanding of those factors is critical. like Kieran said, and the guidelines are really supportive of this, is that the guidelines are pushing towards an integration, but there are really no clear models. So this is just a model that we've developed. It's not the model, it's just a model. There's been one randomized controlled trial that was conducted in Norway that showed that this approach was more effective, short and long term, in terms of patients' outcomes, manual therapy, exercise interventions. That research had to be replicated because, for any study, that replication studies are important. And Kieran can maybe talk to some of his work that he's been involved in, America Keith's work as well. But to say that there are a number of studies now that are being conducted, we're running a big 2-center randomized controlled trial in Australia comparing CFT to usual care. There are studies that have been conducted in a secondary care setting with Casper Ursing in the UK, Britain, that has been also looking at developing or assessing CFT within different parts of the clinical journey. So at the earlier phase and then really at the end phase, in terms of people who've gone through the whole system and then are just completely stuck. So we're really interested at, looking at where this intervention fits and how it works within different healthcare systems. The other area of research that we've been really interested in is how we train physiotherapists. And so Kieran and I have been involved with Ian Cowell's study. You might have read some of his research that's come out of the UK. He's done some lovely work looking at the clinical journey for physiotherapists. And as Kieran indicated, we know that physios find it really hard to deal with cognitive and emotional factors because we're not trained in it. And so part of that work is to explore how it is for a physiotherapist to go through that training program. We're also involved in other research up in Finland, which was an implementation study looking at the same thing. And the message we're getting is that for some people it's relative, it's an easier fit. For others, it's really tough. And so it's not a matter of you need X number of hours. It's a matter of how long it takes to develop competency. And like behavior change for our patients, for physical therapists, it's that ability to look at yourself working, to watch a video, to be critiqued, to have point feedback, to go back and do it again. You can't often learn this stuff just from sitting and watching and reading a book. And that's like real world working with a patient and being mentored and have that point feedback. So that fits really well within the psychological literature in terms of how psychologists work and having that point feedback and mentoring. And I think we often stop doing that once we graduate. We don't have people watching us and giving us feedback. And to me, that's important. In terms of the future, this is not a cure. This is trying to do who really get caught out in our health system. And so we realize that we need to get better at tracking people when they fall out, when they have pain exacerbations. We need to get better at facilitating behavioral change with people. Some people find it incredibly hard. Others are caught in very difficult psychological situations, social situations. We're interested in the integration of care with GPs, physios, and psychologists, how that works, so that we're working within an integrated model. So that's kind of where our future's going. And then applying this to other pain areas as well, like the knee and the hip and the shoulder and the neck.
That's really, really interesting. And Kieran, I want to kind of dive into, Peter had kind of mentioned your research a little bit in particular on that. Do you mind diving a little bit more into that and some of the other stuff you've been involved with as well?
Sure. So, I did my PhD looking specifically at some of the more traditional aspects of physio practice. And so I looked at sitting behavior and sitting posture and how that's related to back pain and what people think about it. And again, it reinforced many of the stereotypes out there that members of the public and physiotherapists think there is a right way to sit, and it definitely wouldn't be the way you're slouched there relaxing on the chair, Brandon. It's much more around sitting like you would in the military. But all the evidence tells us there's no particular posture that's miraculously effective, or that there's no particular chair that's particularly good. So that was, I suppose, some of my earlier work looking at, well, what we do and don't know about the physical characteristics or the physical factors involved in back pain. And then I suppose building on that, then we started to take the safety intervention that Peter described in the Norwegian trial and see, well, can we apply that in an Irish context? So we've just finished and just submitted for publication last week a trial by Mary O'Keefe, an Irish physiotherapist. And for that trial, we compared CFT to a group intervention. which is basically like CFT, but the information given was generic and standardized to all patients. So what we managed to do was take over 200 patients and treat them in the public health service in Ireland and try and see what happens to their pain and disability over that period of time. And what we found is that the personalized treatment was significantly better at reducing their disability than the pretty evidence-based group intervention. Interestingly, the pain differences were not significant. So we're seeing that tailored intervention was better at disability, but unlike the Norwegian trial, the difference in pain wasn't as significant at all. And again, there's probably some reasons for that. And again, it goes back to that idea of, as a researcher, trying to replicate findings in different contexts. So if you look at by a different group, the StartBack trial run by Kiel and the NHS in Britain was one of the biggest and best trials done for back pain for many years. And they showed, very useful effects from using a stratified care approach. And yet that same group trying to replicate that in a different healthcare system in the United States, we didn't see basically any effect at all. Now, again, that doesn't mean that approach is of no value, but it again shows how we have to try and come up with evidence-based treatments, but then also think about how a public versus private system and an acute primary care model versus a tertiary care model, how we best kind of match the needs, our intervention with the needs of patients. Equally, I suppose, then just looking at the effectiveness of interventions, we're quite comfortable with the idea that if we look at other areas of care, like, for example, obesity, most people would agree that what you eat could be relevant in obesity. There's very few nowadays that would say, well, diet is irrelevant. But equally, we know that lots of dietary interventions in themselves don't help. So in other words, you can have something as a risk factor, but that doesn't mean it's easy to address that risk factor. And we see this with lots of the trials of multidisciplinary care or even psychologically informed physio, where we're addressing relevant factors. And that probably is still the way to go, but that doesn't mean it's easy to change these things. And I would say that's particularly the case when we're looking at some of the deeply embedded social issues, looking at job satisfaction, relationships, financial security. And then when we look at the multitude of kind of competing interests and conflicts of interest that are present in a lot of healthcare systems, where the healthcare professional will be better rewarded for providing suboptimal care. So these are some of the things, I guess, that we want to look at into the future. How do we take the best evidence and then match it to the right context and do it in an effective but still ethical manner?
That's really interesting that there's being studies replicated across different health systems. What are the biggest critiques that people have mentioned regarding CFT?
Where do we start? So, I don't know if you want to take that, Kieran.
I'll discuss the psychological aspects first, because I guess the complexity thing is an issue which we'll come back to. Yeah. But I guess, again, on that point, there is that feeling sometimes that if when I'm trained as a physio, look, that's where my core training was in terms of manual therapy and some exercise and analysis of movement and so on. And again, that's still part of what I do. But you cannot look at the literature on persistent pain and think that it's all just about kinematics, anatomy, and movement characteristics. And so my solution then is, right, well, do I just stick to what I do and abandon people? I don't see that as being reasonable. Do I refer them to a psychologist? I would say most countries that's not an option, because A, there isn't enough psychologists out there in general. B, the ones that are there are not particularly trained in persistent pain. And finally, for the average patient out there, there's a large stigma in terms of being referred to a psychologist. So it's perfectly acceptable in Limerick to say I'm going to see my physio or chiropractor for my back pain, but not necessarily my counselor or psychologist. So if we're happy that these factors are relevant and somebody should do something about it, the question comes back to, well, who? GPs are, I would say, are very well positioned to that, but they are typically time poor. Psychologists, lots of skills, but probably considered inappropriate by patients, not by me, and again, not enough of them on the ground. And so I would say that leaves a huge amount of room for physios, chiropractors, and a whole range of other conservative rehabilitation professionals to do a little bit more. Now, the question, we wrote an editorial recently on this for BJSM around, well, what do we mean when we talk about psychological factors? Because a lot of the time we're not dealing with psychopathology. It's people being worried about what they've been told by a physio or a doctor in terms of bending being dangerous, their back being damaged, their MRI scan, looking suboptimal. And they're the kind of things a physio or a doctor can do quite well. And then a lot of the other psychological factors are the stuff that we all experience. So I don't know anybody who has never at any point in their life never had any stress or worries or some poor sleep or not enjoyed some of the people they work with or the people in their families. And again, that doesn't mean we have to try and fix these things. A lot of the time it's just making connections. So often we'll have patients who are very distressed about their pain and are reassured by the fact that, well, even if we haven't fixed it today, understanding that it's probably as much related to the fact that you've been working very long, not had time for exercise or good sleep, that they are as relevant as any disc bulge or ergonomic chair. That can be reassuring in its own way, because once they get through this turbulent period, normal life can resume. So in no way am I, or I suppose in our approach, are we trying to take the place of psychologists. There's clearly still a role for specific mental health professionals, particularly in more severe cases. And in terms of, I think there's a great value in having physios, psychologists, social workers, OTs, giving a similar message. But for most people with persistent pain, a person who is not a primary mental health professional can still have a very large role, I would say. Pete?
Yeah, so, obviously concur with all of that. I think the other thing that we hear as a critique, one is that scope of practice issue that you're highlighting, Kieran, which is a very common one. And that often comes from our own profession, not just other professions as well. And in fact, I saw an interesting systematic review that just came out on social media by psychologists looking at the effect sizes of psychologically informed interventions in physiotherapy, and they indicated they were pretty small. The question then is that because we're not skilled and equipped to deal with that? And that kind of tips into the second big critique that we hear, is that this sounds all very complicated, and are we just making something that should be simple way too complicated? And look, my view on this is, I think, Karen and I have talked about this as our team, and it kind of fits a little bit earlier into what we talked before, that for a lot of people with back pain or musculoskeletal pain, they're going to get better whatever they get. The key thing is not messing that up, not over-medicalizing, not over-treating them, not scanning them too early and frightening them, but just to support them through that journey where the natural history can take its course. The problem is for the 30% who don't get better, they're the vulnerable group. And I think you need extra skills to better support them. And that's around those cognitive, emotional, and behavioral aspects around pain. I think one of the things that we've seen in training physios is they're often very frightened themselves of pain. And we don't like to get people to do things that other people are distressed about. And I can think of numerous patients I've seen today who are terrified of bending or twisting or moving in a certain way. And you have to be confident actually you're not doing harm to them. They may be distressed, they may even feel pain, but you're not doing harm. The training process actually is about upskilling and building confidence in the PTs to better understand and deal with pain in a way that they can confidently work with the patient. And that does take time. As I said, for some people that's quicker, for others it takes more time. So I don't take apologies to the fact that it takes time to train people. You don't become an orthopedic surgeon on 3 weekend workshops. And you take 6 years to do that. And often we think that physio intervention should be learned in a couple of workshops. We're actually believe that a lot of these skills should be embedded at basic training programs, and I think they're starting to. But that would be a whole lot easier for us, because often we have to do a bit of untraining and then retraining, although there are many aspects around physio practice that I think integrates very well with this approach as well. So I think shedding some of the beliefs and building confidence, and then developing skills around more effectively listening and being person-centered in care, and directing patients around their goals, not around our preset conceived ideas of what they should do. They are the kinds of things that seem to be important in developing skills that I think there's probably not much, there's probably a bit of a lack of understanding with people who may see this as a very complicated approach. And in essence, it's a very simple approach. The complexity is I can think of the gazillions of hours I spent learning to do very minute assessments of joints, and really it didn't mean jack. If I'd spent the time developing better skills around communication and motivation and coaching, it would have been a lot better use of my time, I think.
No, that's fair. And something that I've noticed, because a theme that's been brought up along the podcast has been that should we look at our change in admission criteria for new physios? So I know there previously in some schools had been more of an emphasis on things that were easy to measure, GPA, and more of the academic background, but now kind of looking more and considering prior experiences, social skill, those kind of things too. So we're starting to see that here, which I think is a good step in the right direction, at least. And I'm not sure how huge that is in the research as well. But, in going back to that research though, I recognize sometimes this could be very, very hard to measure, especially some of these things like alliance, pain, what type of, just some of these things, I could see how that could really be conflicting and really hard to measure to therefore get accurate results. So, how do you guys isolate these variables to the best that you guys can, along with some of these other challenges in researching this topic to really get the best data we can get?
So you're raising a couple of questions on that. One is, how do you screen people? I think we're lucky as physiotherapists. We're naturally people who love to be active, and we're people who like communicating with other human beings. So that's a really wonderful starting point, I reckon, in terms of developing further skills. And that's why I think often younger physiotherapists or physical therapists find this approach a bit more easy than others. In terms of identifying, if I've got your point here right, in terms of identifying the relevant factors, all the guidelines now are saying that we should be doing multi-dimensional screening of every patient that walks in the door. Our practice does. So no one can get through our door without filling in an Ourobro screening questionnaire. It's a 10-point screening questionnaire, and it asks the patients about their levels of pain and disability, their beliefs, their stress, their worries, their beliefs around work and physical activity, etc. So it's such an important message to the patients who walk through our clinic to say, we're interested in all these factors. We also then evaluate those things you can watch for change in those factors. So they become part of your assessment where you can then check in with the patient around those different dimensions and then look at targeting them. So certainly within a clinical setting, the use of those screening tools I think is very, very helpful. From a research perspective, all of our studies now look at cognitive, emotional, and behavioral factors. So things like self-efficacy, avoidance behaviors, mood, etc. And the interesting thing is it looks like this approach is shifting a number of those things particularly like self-efficacy, which we know is really is quite closely related to disability. And that's about empowering the person to take control of their life, to get back to work, to go and be active, etc. And often you'll see shifts in terms of their fear around activity and movement, shifting around that as well. So I kind of wear the two hats there. We look at all the dimensions in terms of a research space. The other thing that we're looking at the moment, we've got a number of projects, is looking at the physical behaviors to see how closely a change in physical behavior matches with things like a change in terms of cognitions and emotions. And it looks like things like protective guarding. It's not so much about posture, as Kieran said, but people are really frightened. They guard themselves and they move slower. So speed of movement, freedom of movement, co-contraction, they're the things that people use, which is like the handbrake on the back while they move because they're frightened. They're things that we think are probably relatively important, but they're probably a secondary effect of the fact that the person's just frightened and not confident.
So just come back to your original point there, Brendan, on the the use of the GPA and those kind of things to look at people coming into physio programs. I have mixed feelings about it. On the one hand, we'd all agree that just having a high GPA or doing well in your high school exams isn't all you need to be a physio. And so I would have particularly thought a couple of years ago that getting people to do personal statements and looking at things like how much volunteer work they've had or shadowing of other physios, that would be very useful to have in terms of assessing their ability. However, I guess other people have highlighted to me that even things like for example, your ability to get some shadowing of work experience and volunteer is probably also an indicator of your socioeconomic status. And if we want to try and make sure our workforce is truly inclusive, we don't want to just have the people whose family are financially secure enough that they can afford all the extra activities. And then in my role in the University of Limerick, we used to get personal statements for various programs. And to make a broad point, the people whose family members were physiotherapists or worked in healthcare wrote much better personal statements and were better informed. And that might be a good indicator and that they have a better insight, but it also might just be an indicator that they know the game and know what to say. So I still haven't come up with what that correct mix is. But, nowadays, even with personal statements and all these other things we can do to pad out a basic high school degree, they all have limitations in their own way. Then I suppose following on from that point, the other thing you mentioned was, I suppose, some of the things we try and measure, try and figure out what's going on. As Peter said, in the trials we've done, we haven't really measured some of the physical characteristics, and I think that's a thing we should add in. And the current trial, which is quite different to the one that Peter is involved in Australia, will look at how people's kinematics and so on change during treatment, which will tell us what, if any, role changes in muscle activation and the kind of movement patterns have. The other thing we're involved with at the moment, a PhD student of mine in Limerick, John Hurley, is looking at updating and revising the Working Alliance inventory, which is a measure of how clinicians and patients interact. And so he's just finished a cohort study, and we're looking at kind of doing an analysis of how that relates to outcomes and trying to update it to better reflect the kind of things that are important in a physio-patient relationship. And again, while I don't think in any sense that on its own will be the be-all and the end-all, we know that the effect sizes of specific treatments, massage, exercise, injections, are modest. It looks like that the effects of these non-specific contextual effects, whatever we want to call them, are not far off being as big. So we should probably try and maximize those, again, as long as we can maintain an ethical standard of practice.
I think that those are some really, really good points. And I think that, obviously you guys have put in a lot of time to really understand kind of what are the aspects behind CFT. I'm interested in, and you had kind of mentioned some of these, but what are the most challenging aspects of treating patients with persistent pain using CFT? And how have you adapted over time to these? Because, you talk a lot about fear of movement and trying to get people to understand that, movement is okay. What are some kind of examples that you have come across, and how have you adapted to them?
So if I take that one first, I touched on this before, but for all the concern physiotherapists and doctors have about psychological factors, for me, the big challenge is the social factors. So for sure, depression and anxiety and catastrophic thoughts are really important, but I think a lot of those can be managed appropriately with some advice, some exposure, and so on, and some cognitive strategies. The social factors, however, if we're honest about most of the interventions offered for persistent pain, they are clinic-based or are based in a work setting. And while we are very aware of the influence of social factors, they're probably something that's considered a little bit too hard to address. And when I say social factors, I mean the stuff around your work situation. Are you in work? If you are in work, how satisfied are you in that job? If you are getting paid, are you being bullied? If we look at your family situations, your relationships, have you got dependent relationships or close relationships that are less healthy or less ideal than we would like? If anyone wants to check out the TED Talk on upstreaming, I think it applies to a lot of what we're talking about here, that for sure we need to look at people in the clinical environment and help them in their short term, they flare up the storm that they're currently going through. But if we look at the recurrence rates, looking at these big social factors are, first of all, difficult. And also I would say then the current health models in a lot of countries don't help that environment further. So if you live in a situation where if you're not wealthy, you can't access good healthcare, that's going to be a big problem for you as well. And so if I look at how CFT might evolve into the future, I think one of the things we'll have to try and do as much as we can is try and get a better ability to buffer people to withstand their current social challenges, and or get better involvement of social workers and other services. And indeed, some of it I would say would come back to public health campaigns to try and prioritize things that can help people in terms of, if you live in an area which is a bit deprived, is there still safe walking spaces and safe parks and recreational facilities and public transport and all these things that improve your quality of life. But I'm at risk of leaving the healthcare podcast and getting into a political podcast, so I'll leave it at
that. Well, guys, you both brought up a few of these points earlier and some kind of touches on this. But how do you think that, CFT and even management of the person with persistent pain should be integrated into physio entry-level education? Like, because I know that there are some programs that are some that maybe aren't doing as much. What's kind of the best way to go about doing that on a grand scale?
Yeah, so with colleagues at Curtin, Tim Mitchell, Darren Beals, and Helen Slater, together we've put together this ebook called it's a clinical framework for management of musculoskeletal pain from knowing to doing. And this ebook has really been developed to support programs where it just looks at the different dimensions that we know are important around pain and has case examples and support systems that go with it. And we've actually had an amazing uptake of this across medical, chiropractic, physiotherapy, osteopathy. A number of programs have said, look, this makes sense. It's evidence-based. It's kind of logical. It's sensible. And where, that implementation of that framework at an undergraduate level, both a competent, sensible healthcare practitioner that can understand that pain is way more than just the structure. The structure may be really important in some cases. It may be partly important in other cases. It may have nothing to do with the person's pain in other cases. You need a system that is flexible, that can adapt to an individual to understand that. So that's what we have been doing. The problem is a lot of these programs are really, really full already. So you have to let other things go to embed this kind of process in there. And that's often where the sticking point is like what goes in the program. And I think different universities are managing that differently. I know for some universities, they're just rewriting their whole programs. And I think that's fantastic because I think it takes the profession forward a massive leap to just equipping young therapists to just understand pain better.
From my own perspective, again, I'd second what Peter was talking about there. And at Limerick, we would try to adopt a similar philosophy, at least within the MSK field. I was talking to somebody recently who was developing a new physiotherapy program, and one of the discussions we had was around how brave can you be in terms of if you come up with the ideal evidence-based blue sky physiotherapy program, will that be accredited by the relevant professional bodies and be considered applicable and acceptable to the clinical educators who you need on side, to supervise and mentor the students? And that's a tricky balance because, I would like to maybe design a certain type of physiotherapy program, but that means the educators involved have to sing from a similar hymn sheet, the national accrediting bodies in my own country, but also if I choose to go internationally. And that's where organizations like WCPT and IFOMT and these kind of organizations have a big role to play in terms of setting standards. But as Pete said there, one challenge of that is it applies to clinical practices. So we keep telling physios and health professionals, do more of this and more of this. But part of that has to be letting go. And part of that is me saying, like, well, can I afford to do a little bit less of, say, manual therapy? But also even from the perspective of the physiotherapy profession, which jobs in the healthcare system are most important for my profession to provide? And can other people do this, do this job more cheaply and simply, and I'll focus on other work. One challenge, I guess, then, which I think a lot of programs still struggle with, is that we still teach these programs, understandably for timetabling reasons, in silos. So Pete and Tim Mitchell might, for example, be involved in the MSK field, and there'll be other people doing the cardiovascular and the neurology and pediatrics. And one of the points made by Dan Churkin last year at a conference I was at was that you can't really, if you're a GP, be trained to have a certain type of interaction with a back pain patient and, consider these factors. And then next, you've got somebody coming in with a chest infection and a sore throat and transition to a completely different kind of philosophy of healthcare. And that if we really want to embed this biopsychosocial approach, we don't have to call it CFT, but that philosophy, it has to be across, frailty in the elderly and breathlessness in asthmatics and management of diabetes and mental health and persistent pain, that there is an understanding of screening out for red flags, monitoring specific pathologies, and then trying to identify where do we go from there. Where do we start with the simple things and then build on that? And I can't think of any program that I'm aware of that has done that well, because it's much easier from an administrator point of view, say, right, Pete, you're going to teach this subject in those times, and Kieran, you'll do it another time. But in my blue sky days, that's what I think we need.
I think just on that, Kieran, I think there is a general consensus across a whole bunch of health conditions that the same factors look like they're important. The manifestations may different pathological processes, but underlying them are the same kind of foundations. And to me, that's just good sense.
And I think that's why when we look at the outcomes for these kind of conditions like back pain into the future, we want to make sure we're measuring multimorbidity and comorbidity and consider those things as part of our outcome. So for sure, we'd like their pain intensity on a 0 to 10 pain scale to reduce, but absenteeism, quality of life, admissions to hospital or healthcare seeking for other conditions, all these things are probably markers of distress and disability with similar underlying risk factors.
Yep.
I definitely agree with you, Kieran, about how we sometimes have a tendency to practice in silos. I know that Pain Ed does provide talks and workshops, and you and Peter recently did do a course on CFT. So my question then is, Peter, what have you found to be the most effective strategies with teaching CFT and other providers? And then Kieran, if you want to answer afterwards.
Yeah, this is a question that is very close to my heart, particularly given we're involved in this big trial at the moment where we're training up a number of PTs in 2 different states to deliver this intervention in a trial, and it will be the biggest trial yet of CFT, and it's really a test of how well we can generalize this. And it's been a really interesting journey for me of taking people who I've had no prior knowledge of, and then taking them through a training program. So this is like a double intervention, really. It's an intervention of the physiotherapist or the physical therapist it's an intervention also of them. What's the efficacy of the intervention? It's a really important study, and it's a study that we will learn a lot from, whatever the result comes. There have been a number of studies, as I mentioned, Ian Cowell's, there's a study up in Finland as well. And what we're learning from that is that the workshops that we run are interesting and informative, and watching an expert clinician work gives people an opportunity to go, wow, that's, I wouldn't have worked that way. Gee, you're brave. You're way more confident with dealing with pain. Isn't that going to break that person's back? All these beliefs kind of get exposed in those workshops when you watch someone manage someone with difficult pain problems. Or I would have never asked that about that person's life, or about how they feel, and how do you deal with someone who breaks down and starts crying with you. So those are the kind of watching things, but the doing things is where the real change really occurs. And that's a real challenge for us. We've developed resources around an ebook to try and upskill people, and we're assessing those resources, but it's the doing bit and the watching and the point feedback that in my mind is where the real change occurs. I think some people can get nearly, don't need a lot, others need a lot more support. And that's just the nature of change. So the most effective ways of teaching is, first you have to understand it, you have to see it, and then you have to do it. But the doing always has to be in there, because we know that we've seen people who go, yeah, I've been to 3 of your workshops, I'm doing this. And then we watch them and going, do you realize what you're saying and what you're doing and the messages you're giving that person are not consistent with what we're seeing? And so it is not enough to watch. It is not enough to read. The doing is, in my mind, the key.
I appreciate that, guys. And, the big question that we always ask at the end of every episode, it's kind of our big cheese, is if you could change one aspect of healthcare education, whether that be physiotherapy or grander healthcare related, which aspect would you change? How would you change it? And Kieran, I'd love to kind of hear your thoughts first, and then Peter, I'll give you some time to think about your answer.
Cool, because I guess if I was going to talk about just simply healthcare education in the micro sense of when a clinician is educating a patient, I would talk about the need to do less talking and more listening. So rather than feeling I need to pass on all I know as the expert, have a little bit less time in that authority figure position of doing the telling. In terms of healthcare education as a whole, I think my biggest thing I would like to try and look at is while it's nice to have expertise in musculoskeletal or cardio or neuro, but to step back and have a broad philosophy of healthcare across all those different domains, looking at the biosocial risk factors and then developing strategies to help that person self-manage their condition. I think we do that well in some conditions, like for example, if you look at even things like type 1 diabetes, we're getting more familiar how we combine medication management with diet and with exercise and so on in some conditions. But there's still a big sense in other conditions, including orthopedics, that treatment is something somebody else provides to you.
Yep, I would definitely concur with that. And probably the other bit that is close to my heart is just the beliefs that underpin pain. I think, as a society and as healthcare practitioners, we hold beliefs that are just not evidence-based. We believe pain means you're damaged. We believe that a disc bulge means that you shouldn't bend. We have these beliefs that you should keep a straight back when you sit and when you bend, that if it hurts, you should avoid, that it's dangerous to exercise. Like, those beliefs are so pervasive. We see that, like, I can think of a dozen people I've seen today who hold those beliefs. That's had a devastating effect on their condition, and they've been given those beliefs by healthcare practitioners. So on top of what Kieran's saying, I think it will take time to shift that. But, we need to change our understanding and the way we communicate pain to people, because people have a fundamental belief damaged and therefore they need to protect. The majority of cases we know is that pain is more like a headache. It's a backache. Scans don't often look perfect, but what you see in a scan is often a very poor predictor of their outcome. People's illness perceptions look to be more important, and we influence them with the messages that we give them and the things that we tell them in our implicit messages. They're not even spoken. They're the things and the ways that we operate with people. That's a massive shift, I think, for us as a society and as a profession, to actually walk away and understand that those beliefs are not well supported and can actually do harm to people.
Well, this has been a wonderful conversation, you guys, and we thank you so much for taking time out of your day and talking to us. And I know that there's going to be a lot of questions after we're done with this interview. So if people want to look you up online and ask you a question or want to learn more about CFT, where can they find you?
I think Twitter is probably the best option in terms of, you can look at the website, for example, pained.com, and we're both on Twitter, and that's probably a good medium of communicating with several people at the same time, rather than I think everybody in the world has enough emails.
Yeah, I agreed. And I think the kind of questions that we see a lot of recurring questions that come up on social media. They pop up again and again and again and again and again. And it's like, oh, not again. But I think that's a good place. And we can easily share knowledge. And the other thing about social media is you get other people who are wise and knowledgeable also sharing their views, because it's not just us that's involved in research. We have a large team we're linked to, and there are a lot of other great people in the world who have got some great wisdom on the way we manage pain. So, we're part of a large community, and that can be shared within the social media space.
Oh, no, absolutely. I mean, network is incredibly valuable, especially from so many domains. I mean, because no one can know everything, and it's so great to be able to have so many people with that. But guys, thank you so much again for the time and for everything. I know you guys got a lot of stuff to get back to doing, but we thank you so much for everything with that. Keep up the amazing work with what you guys are doing, and it's been a pleasure.
Okay.
Thanks so much. Pleasure talking to you.
Thanks very much for the invite.
Access to healthcare is one of the largest issues facing both providers and patients, as millions of people worldwide lack timely and affordable access to healthcare. Anywhere Healthcare, a telehealth platform, is a simple, low-cost option for providers and patients that eliminates the barriers to access to all kinds of healthcare. To find out more, check out anywhere.healthcare, which is available on our show notes. And if you use the code HET in all caps when you email to sign up, you'll save 25% off the total cost.
Thank you for attending class today, and we hope that you learned something and gained value from the content.
If you'd like to schedule office hours with us, feel free to add us on Twitter at HET Podcast, on Instagram, HET Podcast, on Facebook, the Healthcare Education Transformation Podcast, and the homepage, healthcareeducationtransformationpodcast.com.
And for those of you following along in the syllabus, Extra credit can be obtained by liking us, sharing us, and leaving a review.
Let's continue our journey up Mount Educational Success as lifelong learners.